I'm sorry, I don't have the photographs right now with me. This is a 6 months old fracture, shaft or distal part of the tibia in a 7 years old child, managed conservatively, now presented with 35 degrees of varus angulation, likely to remodel or what? That's the presentation. Sorry, this is a valgus. I'm sorry. This is that presentation to us. This was 6 months old fracture. This is wrongly written, whereas this is actually a valgus angulation. So how many of you will think this is going to spontaneously remodel? Spontaneously remodel, because this is only a 7 years old child. Yeah, child is walking like this with a valgus. How many of you, show your hands, how many will think this is going to remodel? And how many of you think this is not going to remodel? So quite a lot. So it requires a corrective osteotomy. I agree with that. It will not remodel. So this is the acceptability of angulation in tibia. This is from the Rockwood and Green, not more than 5 to 10 degrees basically.
Dr. P. Gupta, any role of growth modulation over there?
Yes, one can consider growth modulation, but yeah, this is near to the growth plate. One can consider growth modulation. Yes, this was done at a time when figure of 8 plates were not available easily. This is the old slide, so this is I think 6 or 7 years old.
At the moment, you would do a growth modulation in such a child?
Yes, I would do.
So that's the message now. Osteotomies are going out. More and more people are opting for growth modulation, which is a temporary epiphysiodesis of the.
The only problem with growth modulation is that this is not the end which is growing too much. The distal end of. So growth modulation, if you see the classical literature, it's been described only near to the knee region and near to the growing ends. I did in 2 or 3 children around 10 or 11 years of age with the ankle valgus. I did put a medial plate. They have not remodeled to my full satisfaction, and there is no criteria given in the literature how much remodeling is going to occur.
Slow growing site. The other thing is the fibula. What do you do with the fibula? Do you stop the fibula as well, or you just put it on the tibial side?
This would be a medial basically.
So you would not do anything with the fibula. What happens?
No. This is a valgus, na? So you have to stop the medial growth. So you put a plate on the medial side. In this particular patient.
No, what I'm asking is, that's it, you do it for the tibia.
Yeah.
What will you do to the fibula?
For a varus
deformity. Even for a valgus, what you are going to do for fibula? Because what happens if you stop the growth of the tibia on the medial side, fibula tends to become longer because it's growing normally. So they have described putting a screw through into the fibula.
You can do a screw through. Yes, you can do that. No. Yeah, this is a closed wedge osteotomy. It was not much in this child.
That is the beauty of doing a growth modulation. Everything is safe for future. So you may do a growth modulation at present and then later do an osteotomy if it is not corrected. And everything is safe, you have not burnt your bridges and you're really on safe ground. So that is the big advantage of doing a growth modulation.
So a 2 years old girl, any takers for what the injury is? So lateral condyle, I think you guessed it right, but what do you do with that? How many of you would manage conservatively? How many of you would operate?
Can I ask a question, those who are operating, what is your indication for operation in this? Or will you look for something? Why will you operate on this patient? There's a group which is not operating, big group which is not operating. But I would say you operate, but why? Anybody? Would you do something else to this patient? Okay, he's going to take you through.
All right. So basically if you take oblique views, you see this fracture line through and through. Basically this fracture is classified into the classical lateral condyle, which is the type 3, which most of you are aware of. There's a completely displaced fracture, and a type 2 fracture is a through and through fracture, which is more evident on oblique views. And a type 1 fracture is a partial cortex fracture. Type 1 is basically the one which you will manage non-operatively with a cast or a slab, whatever, with a protection. Type 2 injuries, they actually tend to displace. So, pinning is the treatment of choice. You do a closed pinning and that's the end of it. And if you do not operate, this would be the end result. In most of the type 2 fractures. I have had around 15 of 20 of them.
Role of arthrography?
Well, role of arthrography, you can do arthrography, but if you're doing arthrography, might as well pin it also, because it's actually being done under.
What the message should go to this particular audience is that if you have any doubts,
if you have any
in
doubt,
an elbow injury, please do an arthrography. Take the patient under GA, put in some dye and see whether the fracture is going through and through into the joint.
First thing is take oblique views. If you find a fracture line like this in the oblique views going through and through,
which again is very difficult to see sometimes.
Actually is an indication for fixation. If you find that the fracture line is not going through and through, you can manage non-operatively. But if you are taking the patient for orthography, anyway you are going to do it under GA. So if you are going to do it under GA, might as well pin it. This is an undisplaced fracture. Remember, this is an undisplaced fracture. If you leave it as such, this is a patient which came to me after about 4 weeks. This is a displaced fracture, and this was not united. We have recently operated on this fracture. This is not united, and believe me, they tend to displace more than that with passage of time. This was painless, so this will displace more.
And you're surprised at the amount of cartilage that you see when you open them up. So it looks like a small tiny fragment, but it's really, really big.
And believe me, type 2 fractures are not uncommon. They are very, very common injuries. This is a closed, this should be a closed pinning most of the times in type 2 fractures. Just a closed pinning what you do.
Sir, what is the harm in managing conservative and taking weekly X-rays?
They almost always displace. Yeah?
Even in cars they displace,
yes. This was treated elsewhere, and this was after 4 weeks they came to me like this, and I would operate. How many of you would operate on this fracture at this stage? Most of you would. So a simple close pinning at that stage would have saved you of a open reduction for this fracture and its subsequent complications.
Why these type 2s don't heal is there is continuous seepage of
Synovial fluid inside.
because that fracture line is exiting into the joint. That is what prevents it.
So 3 years old girl had a fall 18 days back, pain in the wrist, treated by a local doctor in the form of splintage and analgesics, and that's the way this girl presented. So what is to be done with the callus formation? That's the one which is available. You have to manage with this. Actually, the parents got this X-rays to me. See what is to be done. We'll get the girl. This was about 200 kilometers away. The girl was about 200 kilometers.
Can you show the history again for some of them? They want to see the history again.
18 days back, girl had a fall, pain in the wrist, treated by a local doctor in the form of splintage and analgesics.
So there's a history of trauma in this patient, and significant trauma, yeah, which was managed by splintage also.
So I think somebody guessed it right. Actually, this was we got the child, and there was an abscess there. You can see there. So the clinical examination is very, very important part of any procedure which you want to undertake on any patient. You must do a thorough clinical examination. So this was actually an infection. So that's the message, that clinical evaluation is must, and after sometimes most of these children, they will present to you with the trauma and somebody has done a splintage and you ask that was there a fever? Yes, there was fever after 2 days and the pain increased after 2 days. So all such like cases, one should always suspect osteomyelitis.
This context, I want to ask is, any fracture, recent fracture, should we prescribe antibiotics or not?
Absolutely no. Because if you prescribe antibiotics, there are a lot of fractures which are there. If you prescribe antibiotics, and one, it is totally useless. Second,
You are getting infected like in this case.
it's not trauma. It was actually a mild trauma, which actually was massaged or whatever was done, and then subsequently it turns out to be osteomyelitis. This is a very, very frequent history in osteomyelitis. Child has a fall, some pain in that region, and subsequently 2 days down the line the pain increased and splintage was done and never opened, and child comes with draining sinus or
Patient is suffering from URI or something at that time, point of time, and there is a fracture also. It can, that bacteria can lodge here and get infected.
URI is a viral infection. So basically osteomyelitis should always be kept in mind if the fracture anatomy is obscure to you. So
Oh, good, great. Okay, thanks all of you.